All right, let's dive right in. We're about to simulate a high-pressure surgical oral exam. You might know it as a viva. We're going to follow a candidate as they get grilled on a pretty complex breast cancer case. We'll cover everything from the very first scan to the long-term plan. Let's see how you'd handle the hot seat.
Okay, let's begin. Your consultant exam starts now. You have a 42-year-old female and she's been referred to you because of an abnormal screening mammogram. So what's your first move? How do you proceed?
So here's our game plan. We're going to walk through this just like a real consultation. We'll start with her history, then the clinical exam. After that, we'll tackle the diagnostic puzzle, put together a solid management plan, and wrap up with aftercare and the absolute key takeaways from this whole case.
Okay, so you've taken a really thorough history. Let's imagine the examiner is now asking you to summarize the key details you've just learned. A good candidate would say something like this. Okay, to summarize, I have a 42-year-old woman who has no breast complaints at all. She's here because a screening mammogram showed suspicious microcalcifications. Now, what's really crucial here are her risk factors. Her mother, a first-degree relative, died of breast cancer at just 51. Plus, she has a 5-year history of using hormonal contraceptives. Right away, my suspicion for a non-palpable, screen-detected cancer is pretty high.
That's an excellent summary. You know, what makes this case a bit tricky is that she has no symptoms, so the physical exam becomes absolutely critical for spotting any subtle clues. Let's walk through what a perfect, systematic examination looks like.
My approach is always going to be systematic. First things first, get permission. Make sure the patient has privacy and position her correctly. Then I'd start with a general inspection, looking for any asymmetry or skin changes while her arms are relaxed, then raised, then on her hips. Next up is a systematic palpation of both breasts, always starting with the normal side first. That's followed by a really detailed check of all the lymph nodes, the axillary, cervical, and supraclavicular areas. And finally, I do a quick systemic check for any signs of metastasis, looking at the back, abdomen, and lungs.
Very good. So the examiner tells you, on examination, she's an obese but otherwise healthy-looking woman. Her vital signs are stable. Her breast and axillary exams are completely normal. You can't feel any masses, no palpable lymph nodes. So what's your next step now?
And here's where the case gets really interesting. Frankly, this is where a lot of candidates can get tripped up. You've got a suspicious mammogram, but a totally normal physical exam. The next moves you make are absolutely critical. This is a classic exam scenario, and it's designed to test your entire diagnostic process.
Exactly. So you move ahead with a diagnostic workup. The mammogram and ultrasound confirm this cluster of microcalcifications. Radiology classifies it as BIRIDS4, which, basically means suspicious. So you do the right thing, you perform a stereotactic core needle biopsy, but then the pathology report comes back, and it says, normal breast tissue.
So, let's pause here. You have a BIRADS4 suspicious lesion on the images, but the biopsy says everything is normal. The reports don't match up. They are discordant. So, candidate, what is your decision? And even more importantly, why?
Now, this is one of the most important moments in this entire case. This situation is a major clinical red flag called discordance. It's an absolute exam pearl. It basically means the biopsy probably missed the spot. Think of it like this. You see smoke coming from a window, but the fire alarm inside says it's all clear. You don't trust the alarm, right? You trust the smoke. Ignoring this discordance is a catastrophic exam failing mistake.
For me, the decision is crystal clear. Because the radiology and the pathology are discordant, that core needle biopsy has to be considered non-diagnostic. We have to assume the suspicious lesion was missed, so the one and only definitive next step is a wire-localized excisional biopsy. We have to go in and remove that entire area of microcalcifications to get a conclusive answer.
And that is precisely the correct and, most importantly, the safe answer. So the excisional biopsy is done. And now you have the final, definitive pathology report. Let's see how this report is going to shape our entire management plan.
Okay, so the final pathology is in. The diagnosis is ductal carcinoma in situ, or DCIS. This is a non-invasive, precancerous condition. The lesion is 2 centimeters, low grade, and it doesn't have a more aggressive feature called comedonecrosis. Now, importantly, the hormone receptors are negative, which means hormonal therapy won't work. And here's the critical part. While most of the edges or margins are clear, the posterior margin is positive. That means some abnormal cells were probably left behind. This report is now the foundation for my entire management plan.
My management plan is going to have 4 key parts.
Number 1, and this is so important, I'll break the news to the patient with real empathy and support. Number 2, I'll discuss her case in our multidisciplinary team meeting, the MDT, to get input from everyone, pathology, radiology, oncology. 3, because of that positive posterior margin, she needs another surgery, a re-excision. And finally, after a successful surgery, she'll be referred for postoperative radiotherapy to lower the risk of it ever coming back in that spot.
A very clear, very solid plan. Now, the examiner has a specific question for you. You're taking her back to surgery for the re-excision. Are you going to perform a sentinel lymph node biopsy on this patient?
The answer is no, I will not. A sentinel lymph node biopsy is a procedure to check if cancer has spread to the lymph nodes. But for pure DCIS, it's generally not needed because by definition, DCIS is non-invasive. There are very specific reasons to consider it, like if there's a palpable mass, nipple discharge, high-grade features, or a really large tumor. This patient doesn't meet any of those criteria.
Correct. That answer shows a really nuanced understanding of the guidelines. So the surgery and radiation are done. Now let's wrap this up by looking at the long-term management plan and hitting the most critical learning points from this whole case.
The patient's follow-up needs to be really structured and long-term. So right away, I'll see her 2 weeks after surgery to check the wound and go over the final pathology. For long-term surveillance, she'll get a clinical exam every 3 months for the first 2 years, then every 6 months for the next 3, and then once a year after that. And of course, she'll need an annual mammogram for life.
So what are the big takeaways here? First, having a systematic approach is your safety net every single time. Second, and this was the turning point in this case, you must recognize and act on discordant results. It's a massive red flag. Third, remember that modern cancer care is a team sport. The MDT meeting is essential. And finally, really mastering the specific indications for procedures like a sentinel lymph node biopsy is what separates the good answers from the great ones.
And this just perfectly illustrates a core truth about any high-stakes clinical exam. The examiner isn't just looking for the right answer. They're watching to see if your thinking process is safe, logical, and systematic. Honestly, how you get to the answer is often just as important as the answer itself.
So I'll leave you with one final thought to reflect on. Looking back at this entire clinical journey, from that very first mammogram to the long-term follow-up plan, what do you think was the single most critical decision point? And more importantly, why would getting that one decision wrong have been so catastrophic? Thinking that through will really cement the biggest lesson from this case.